Today on Primary Care, arthritis, a disease affecting 1 in every 3 people between the ages of 18 and 64. For those over 65, the numbers are much worse.
It's in my hands, my feet. It's total body.
Hello, and welcome to Primary Care, the show dedicated to the health and care of African Americans. I'm your host, Dr. Lonnie Joe. Arthritis is the leading cause of disability in the United States, affecting approximately 1 in 3 adults. According to a study released by the Centers for Disease Control and Prevention, arthritis causes more pain, more physical limitation, and more disability for African Americans and Hispanics than for whites. Why? Because many with arthritis also have comorbid conditions like heart disease, chronic respiratory conditions, and diabetes. Joining me today to talk about the effect of arthritis and it has on the body and why African Americans are so negatively impacted is Dr. Angelia Mosley-Williams. Dr. Williams is Associate Professor of Internal Medicine and Rheumatology Division at the Wayne State University School of Medicine in Detroit. She is also the Section Chief of Rheumatology at the John D. Dingell VA Medical Center. Dr. Williams, welcome to the program. So glad to see you.
Thanks for inviting me.
Good. In doing some of the research, Angela, the Arthritis Foundation publication, Arthritis by the Numbers, cites some very alarming statistics about arthritis and several diseases that affect and impact African Americans. For example, 25 to 26% of adults with arthritis also have heart disease. 19% have chronic respiratory conditions, and 16% have diabetes. Has this relationship always existed between the arthritic patient and a community like this?
Absolutely. Unfortunately, many of the federal officials and Arthritis Foundation officials didn't really start to investigate. And when they did, they found out, oh, we think we're controlling arthritis inflammation better, but there was still an increased risk of cardiac death. So they started to investigate and found out that unfortunately rheumatoid arthritis, which has a lot of manifestations, not just in the joints, but in the lungs, the patients with rheumatoid arthritis are more likely to smoke, which is a double negative.
Bad.
Are depressed, therefore they are not as careful with their diet and exercise, have a tendency to eat incorrectly and not exercise, and just greatly increase their risk for hypertension, diabetes, and unfortunately cardiac death.
So even though we see these increasing numbers in minority populations, we have to talk a little bit about whether or not there is a hereditary component to this. Do we see any signals that say, listen, because of your genetic makeup that you're predisposed to these conditions?
Not necessarily. A long time ago, we have looked at genetic predisposition, and it's genetics and environment. And unfortunately, environment has a very large role between being in toxic areas, growing up in those locations, having stressors that the majority population do not have to encounter. Our patients will have more hypertension and heart disease just from environmental factors, and it's not necessarily genetic.
Yeah. So we've looked at some of these things over time. The use of incinerators from what seems to be innocent businesses in the inner cities, the fear of having your children being exposed to these things, how it affects them in terms of days missed from school or asthma. It goes on and on, but I think that the key factor here is inflammation. And that is so exciting because so many of these disease states have an inflammatory component that seems to be the common theme between them, whether it's inflammation in the brain or inflammation in the coronary arteries or inflammation in the joints.
Correct. It is inflammation, and controlling the inflammation is the most important part. In the past, sometimes rheumatologists use a little bit more corticosteroids than they needed to. And that, of course, increases acceleration of high cholesterol and endothelial vessel damage. By that means just hardening of the arteries, as our old folks used to call it.
How do we make the diagnosis of arthritis, osteoarthritis and rheumatoid arthritis?
That's an excellent question. Most times when you see someone who walks into the office and say my fingers hurt or my knees hurt, just using statistics, there's going to probably be osteoarthritis. The prevalence of rheumatoid arthritis in the overall population is about 2.6 million, but the prevalence of osteoarthritis is closer to 30 million and growing. The CDC did a bunch of statistics late last year and they published them, and the osteoarthritis load for African Americans is about 21%, which is surprisingly not much more than Caucasian Americans or Latinos. However, the disabilities for African Americans is 44%. So even though we might have a similar prevalence overall, we have more disability. So how do you make the diagnosis? If the person says my hands hurt, and you look at their hands and there's no soft, boggy swelling of their knuckles, and they say they can just wash the dishes and in a few minutes their hands are better, that's osteoarthritis, okay? If they have lots of hard little nodules, that's osteoarthritis. If they have lots of puffiness and they can't make a fist and they're very tender, then it's probably rheumatoid arthritis, and they usually have fatigue, fever, they're stiff in the morning many, many hours, and they feel a little better when they exercise, but it still takes hours. There's one more other condition that is widely ignored, and that's ankylosing spondylitis, because most men come in and say, my back hurts, and you just figure I just lifted one too many bales of leaves or whatever. And if you have a young man who says, I feel horrible in the morning, but after I exercise I feel better, you can check some x-rays or magnetic resonance imaging of their lower back to see if they have ankylosing spondylitis, because we do have good treatment for that.
Yes, one of the diagnoses that kind of gets overlooked sometime in this whole incidence of back pain and the workup of back pain. Okay, so since we have available in society now so many patient options, what can patients expect when they come to the doctor in terms of, you mentioned imaging, but what about the blood work associated with the workup of these patients?
Believe it or not, my old mentor, who happens to still be working, Dr. Felix Madrid, always said is history and physical. Unfortunately, you have to talk to your doctor. The doctor has to listen. and then you have to examine the patient's fingers and toes. The blood work only confirms the diagnosis. So if you have rheumatoid arthritis, rheumatoid factor will be positive. If you have lupus, the anti-nuclear antibody will be positive. If you have x-rays and you're worried about ankylosing spondylitis, sometimes you can see unusual bone spurs in the lower back that don't look like regular wear and tear arthritis, and the radiologist will know exactly what that is.
Dr. Williams, we have to go to a break. Coming up next on Primary Care, remembering Mrs. Hattie Knox.
Who's most at risk for coronavirus? People over 65, people with underlying medical conditions like heart disease, chronic lung disease, asthma, diabetes, people undergoing cancer treatment, and people with weakened immune systems. What should you do if you or a loved one is at higher risk? Avoid close contact with people, avoid crowds, stay home if you can, wash your hands frequently, learn more ways to protect yourself and others at coronavirus.gov.
Hattie Knox was a proud and faithful member of the New Prospect Baptist Church in Detroit. She had rheumatoid arthritis for over 30 years, which made her well acquainted with the disease. The interview you're about to see was conducted before Ms. Knox sadly passed away. But we felt that her story was an inspiring one, and this is our way of paying tribute to such a beautiful and beloved woman.
My name is Hattie Knox, and I have rheumatoid arthritis, and I've had it for 30 years. It's in my hands, my feet, shoulders, arms, knees. It's just all over. At the first stage, you just feel a little ache here and there, and you get the cortisone shots. But after a while, the cortisone shots, you don't want to keep getting those, so the doctor will recommend medication. And then you also have to know which medication actually fits your situation. And after the medication, I did notice, even with the medication, the shift in some parts of my body. My hands have twisted. My toes have gotten on top of the other toes. The joint moves. It can affect your body to where you can't sometimes make a fist. You get the big knobs on your knuckles. It can be disfiguring. And it can affect you. You know, when you get up, you gotta stretch and get yourself together. Up in here, up in here. Exercise is very important. Even if you're painting, you see that after you do a regimen of exercises, our church has what they call a cheerobics. And in the cheerobics, we lift our arms, squeeze our hands, move our legs, knees, all of that. When I first started, I used to cry, drag myself feet across the floor and stuff like that. But I found out that when I have peace with God and I'm involved in activities with young people, I make a commitment. And when I get up and honor that commitment, no matter how bad I might feel, I try to honor that commitment, and I have peace with myself. Yeah, I feel good about it.
As the nation's doctor, I often get asked, what should I do if I think I might have coronavirus?
People who are sick should stay home. You don't go to an emergency room, you don't go to a clinic. You get on the phone and you ask for advice and instructions from your physician.
We don't want you to go into the ER or the doctor's office without talking to them first, because you might spread coronavirus to someone else. Please visit coronavirus.gov for more information.
Welcome back. We're here with rheumatology specialist Dr. Angelia Mosley-Williams, Chief of Rheumatology at the Dingell VA Medical Center here in Detroit. Angela, once a person has presented and been diagnosed with arthritis, what kind of treatment is available to them?
For rheumatoid arthritis.
Both, yes, of course.
We're gonna do them by each individual type.
Okay.
Expect something called methotrexate. It was used as a chemotherapy agent back in the 70s, but they found out it worked very well for rheumatoid arthritis. It is used worldwide and is responsible for increasing the lifespan of rheumatoid arthritis patients across the world. Since then, we've added things like etanercept, abatacept, adalimumab, and many other biologic agents that are helpful with rheumatoid arthritis. They are costly, but they have made great improvements in quality of life.
And well advertised on television.
Yes. For osteoarthritis, unfortunately, it's still the same pain control, exercise, and at the very end, you may need a joint replacement. The theories on pain control have changed remarkably over the past years. And we used to use lots of anti-inflammatory medications, and now they're known to increase cardiac risks, so we must be very careful. We were told to take care of pain no matter what, so many doctors decided, well, opioids aren't that dangerous, I'll just use those. But that was not true.
Created another crisis, yes.
Created another crisis. So now we're back to the old-fashioned rubbing liniments. Some of them do have anti-inflammatory agents in them. Some are extracts of cayenne pepper, like they did many years ago, and exercise, along now with Tai Chi and yoga. So that's what we have. For gout, of course, is you watch your diet, you take allopurinol or things to lower the uric acid crystal in your blood, and have a good communication with your doctor about the blood pressure medicines that you take so you don't take medications that trigger gout attacks.
Do you have any concerns about over-the-counter products like the nonsteroidal anti-inflammatories that are available to anybody that can just pick it up off the shelf? And the reason I ask that is because we're seeing an uptick on the internal medicine side of the precautions and cautions in terms of use of these drugs, particularly in patients with renal disease. How do you advise patients on the use of those types of drugs at their own discretion?
I like the VA administration's approach, and that is, before you take anything, please discuss it with your doctor. Please make sure that there are not going to be any drug interactions. So that is our approach, and I think it's a wonderful one. So the patient has to be a little proactive. That means don't take medication because Aunt Sally told you to.
Or someone else's medication.
Or someone else's
Yes.
medication. You talk with your doctor first to make sure that even an over-the-counter medication is the right one for you.
So basically, we do have newer drugs, especially in the treatment of rheumatoid arthritis, that have come into play and come on the market that actually seem to be making a difference in the treatment of that particular disease state. What about the side effects, though? Everybody wants to know, am I going to experience it, no matter what we use, am I going to experience any side effects with these drugs? Where are we at with the side effects profile on those drugs?
An excellent question. I, at one time, used to have the honor of taking care of lots of physicians and nurses who had the same concerns of side effects as people who were not in the medical profession. Over the years, we have found this. The medications for rheumatoid arthritis, especially the newer ones, really suppress your immune system. And it is something that is not trivial and must be monitored. So the side effects are pneumonia, more than usual, to which the American College of Rheumatology recommends that every patient get their vaccines as recommended by the Center for Disease Control, and at a younger age if you are going to take one of these medications. The other side effects are sometimes cardiac disease, and very few patients have come up with secondary malignancies. So, and that seems to be what concerns most people, is the scare of cancer.
So if we know the side effects and can discuss them to a great degree with our patients, we can alleviate a lot of the fears of starting them on some of these drugs, simply because a lot of patients are afraid to take anything and are skeptical of what the recommendations are. But here again, when we know and can guide them better, we seem to have better outcomes.
That is true. And I forgot one more thing. For some of the medications, you must get a TB test before you start, and every year, to make sure that you won't have rampant TB.
Very good. We got to go to another break, but we'll be right back with more discussion with Dr. Angelia Mosley-Williams on arthritis.
Who's most at risk for coronavirus? People over 65, people with underlying medical conditions like heart disease, chronic lung disease, asthma, diabetes, people undergoing cancer treatment, and people with weakened immune systems. What should you do if you or a loved one is at higher risk? Avoid close contact with people. Avoid crowds. Stay home if you can. Wash your hands frequently. Learn more ways to protect yourself and others at coronavirus.gov.
With coronavirus spreading, people at higher risk must take extra precautions. You're at higher risk if you're over 65 or if you have an underlying medical condition. Please visit coronavirus.gov for more information.
Welcome back. Dr. Williams, in this whole picture of arthritis, we see patients tell us all the time, oh, I can tell when it's going to rain because my joints act up, okay? Or I know something's about to happen because I feel it in my bones. I mean, can you comment on some of those common types of occurrences that we see in the discussion of arthritis?
I hear it often too. And I actually went to look in the literature to see what the answer is. And what I found in the literature wasn't helpful. What it said was, on rainy days, when they did diaries, people don't have arthritis any more than they do on a sunny day. So it's not more symptomatic on a rainy day. But what you asked me is patients who say, I can tell it is going to rain.
Yes.
Unfortunately, no one's looked to see what happens when the bariatric pressure is changing, so we don't know. And I don't think that all these people are hypochondriacs or making things up, so they're obvious. I think there's something to it.
Right. This comes out in an interview process all the time. What about diet, exercise, obesity?
My patients hear this from me all the time. You heard it from your diabetes doctor, you heard it from your kidney specialist, you heard it from your lung doctor, now you're going to hear it from me. And they roll their eyes. And it is, you have to limit the amount of animal fat, processed sugars, and even artificial sweeteners. You have to eat lots of fresh fruits and vegetables, a lot of leafy vegetables, and you need to get up off the couch. And they roll their eyes, but it makes a difference. The same thing that causes inflammation in your heart and in your blood vessels and in your kidneys increases the inflammation in your joints. And the other thing we tell them, oh yeah, and you need to stop smoking. And that doesn't go over well, but I just keep saying the same thing with a smile every time they see me.
So lifestyle modifications always in place. I'm just not sure of how well we're achieving the goals, okay? Because it's very difficult to change what in some instances are lifelong habits simply because the disease state is set in.
Yes. I typically get, if I can't walk to the restroom, how am I going to walk down the block to exercise? I typically get, there are no heated pools in my neighborhood or safe place to exercise. That is very true. African Americans do have a lot of problems with access to facilities that are safe and clean. What I tell them is perhaps organize people in your church, because that seems to be a very important social institution in black neighborhoods is the church, and to have them have like a walking group or a Tai Chi class, or bring in chefs who can tell you how to redo your green and chitlin recipe, as in get rid of the chitlins, but find other alternatives that are just as tasty. And I think there have been programs started in majority communities and in majority churches where it's made a difference, and hopefully that will happen in the black churches as well.
Angela, we struggle with this whole thing of stress in our society, no matter who you are, what your lifestyle is, or quality, so-called quality of life. Stress seems to be a reoccurring theme as we deal with patients. Do you see an association between stress and stressful situations and disease states that affect the joints?
Yes, we do. Actually, there in the textbooks is long known that stress can actually be a trigger for the onset of rheumatoid arthritis.
So a family situation
Yes.
can present as more pain.
Yes, it can start the rheumatoid arthritis, and if you have osteoarthritis and stress, your brain can ramp up the pathway of pain to the brain, and you just have a generalization of pain, and you don't get that when there's no stress. So stress makes a huge difference.
As a professor of medicine, we know that you rely on the data a lot. Where do you see the improvement, or has there been an improvement in African Americans participating in clinical trials in the rheumatoid space?
Unfortunately, not a lot of improvement. There have been groups of doctors who've gotten together who try to recruit their patients, but it's in certain locations. But as a systematic increase in the number of African Americans in clinical trials, unfortunately, it's not happening yet.
So we potentially could run the risk of having chosen medications to treat a disease like rheumatoid or osteoarthritis, only years later to find out, like we have with so many drugs, including the tamoxifen study for breast cancer in women, and wondering why it didn't work, why we didn't get the outcomes that we were expected as compared to other populations of people. I mean, if we're not participating, if we're not part of the studies, how can we actually include the ethnicity story in this whole treatment program?
You have to tell your patients that this is what the studies show. there was only a 2% inclusion of people who looked like you, and it's a guess that it's going to work as well for you as it did for the majority of the people in the study. And you just have to give them that caveat and let them help you decide what's good for them.
Excellent discussion. This has been very beneficial, I know, not only to our listening audience, but also to us who learn as we go along in these disease states. We've been talking with Dr. Angelia Mosley-Williams, Associate Professor of Internal Medicine and Rheumatology at Wayne State University School of Medicine in Detroit, and also the Section Chief of Rheumatology at the John D. Dingell VA Medical Center. Dr. Williams, thank you so much. It's always a pleasure to see you. This has been most informative. Thank you for coming.
Thank you for having me.
Excellent. Arthritis affects millions of adults in the United States, and a number of those affected continue to rise because there is a strong relationship between arthritis and other conditions that disproportionately affect African Americans. We must find ways to work with researchers, specialists, and our primary care doctors to improve health outcomes with early diagnosis and effective treatment. Thank you for watching Primary Care. I'm Dr. Lonnie Joe.